Good afternoon, everyone. Welcome to today's webinar. We're thrilled to release our national survey of peer recovery coaches as part of work to focus on strengthening the opioid use disorder behavioral health workforce. I'm Karen Scott, president of the Foundation for Opioid Response Efforts. On our agenda today is quite full. We will be focused on sharing with you the main results from our national peer survey, along with the specifics of the methodology, and then have a very distinguished panel of guests to react to the survey results and take us into a discussion about how we build and support this workforce. We will have about 15 minutes towards the end of the webinar for a question and answer session. Our panelists today include Dr. Robin Rappaport, who's Executive Vice President at SSRS, which is an international survey firm, Paolo Del Vecchio, who's Director of the Office of Recovery at SAMHSA, U.S. Department of Health and Human Services, Dwayne Dean, who holds many roles, including serving as a peer recovery specialist and trainer and faculty at the University of Maryland. Justin Reed is statewide coach coordinator for the Maine Recovery Hub and Portland Recovery Community Center. And Gordon Smith is director of opioid response for the Governor's Office of Policy and the Future of the State of Maine. Just a couple of quick reminders. We do make our webinars available after the session. So the webinar will be recorded and posted on our website shortly after the session ends. The presentation slides, as well as the survey reports, will all be available for download from our website as well. During this session, please use the Q&A button found at the bottom of your Zoom screen for asking questions. That also allows you to upvote a similar question if you see one there that you are particularly interested in us trying to get to answer during Q&A. Thank you again for your participation and attendance today. We will have a brief survey right after the webinar. We always benefit and hope to get your feedback as we plan future programming. Right. Just very briefly, for those of you who are new to FORE, the Foundation for Opioid Response Efforts is a private national grant-making foundation focused on supporting solutions to the opioid crisis. We were launched late in 2018 and support a range of projects around the country with a focus on advancing patient-centered, evidence-based solutions to address the opioid crisis. Our grants focus on supporting professional education, supporting innovation, and piloting different approaches to improving access to treatment and recovery services through payer and provider strategies, work on policy initiatives, as well as increasing public awareness. In addition to our grant making, we do regular convenings such as these webinars and develop a range of resources to contribute to the field. This survey is an example of one of those resources where we hope the data from the survey can really help inform ongoing discussions about this workforce. We're going to get right into the survey findings now, and I'm pleased to introduce my colleague in this effort, Robin Rappaport, from SSRS. Robin's going to take us through the methodology.
Thank you so much, Karen. Okay, so queuing to our first slide here. Okay, so with the survey of certified peer recovery coaches, FORE hoped to better understand the experiences, needs, and challenges faced by certified peer recovery coaches across the country. Now, the survey was informed by a two-phased qualitative study that SSRS conducted in the spring of 2021 on behalf of FORE. All aspects of both the qualitative and quantitative research were reviewed by an advisory group established by FORE, consisting of academic researchers, people with lived experience, and those directly involved in supporting PRCs. A key challenge for the quantitative study was developing a representative sample, since the certification process varies across states and there is no national registry of certified PRCs. In lieu of a national sample source, SSRS collaborated with the FORE team to leverage relationships between FORE and individual states and their certification boards. Specifically, SSRS and FORE reached out to the FORE team's contacts in states across the country, introducing the survey and asking if they'd like to participate. Significant efforts were made to engage certification boards and other organizations to obtain samples that would be representative of the population of certified PRCs in each state. The foundation of this study is built upon the willingness of these organizations to support this endeavor and provide the necessary information and resources to reach PRCs in their states. Ultimately, we were able to directly partner with a total of 6 organizations encompassing 9 different states noted on the slide. The close collaborations with these organizations and their support of the overall survey research goals helped build trust and engagement with the certified peer populations in each state, which further enhanced both coverage and cooperation. We were also able to procure publicly available contact information for PRCs from 2 additional states, Ohio and Idaho. Okay, great. So key components of the methodology included obtaining IRB approval, developing and finalizing the survey instrument, outreach to PRCs, and other data collection efforts. Obtaining IRB approval ensured that we properly protected the rights and welfare of the PRCs we interviewed. We obtained approval for all aspects of the survey of certified PRCs from the University of Southern Maine Office of Research Integrity and Outreach, IRB. Specifically, we worked with USM's IRB to define the research protocols for the cognitive pretest interviews in the final survey instrument, including making IRB consent language available to potential respondents at the start of the web survey. SSRS submitted all invitation and reminder emails, as well as survey instruments in English and Spanish, to the IRB for approval before launching the survey. The survey instrument was developed based on findings from the qualitative phase and in discussion with the FORE team. Along with FORE's advisory group, the SSRS and FORE teams iterated to finalize research topics and priorities, including question wording, with the overall goal of ensuring the survey would yield the most valid data. Along these lines, we also shared the survey instrument with the state-based collaborators to ensure the questions would be well understood by PRCs in each of the participating states, and also that the survey would yield meaningful findings for our research collaborators in each of the participating states. Given FORE's goals for the survey, the criteria for eligibility included current peer certification and support of those experiencing opioid use disorder. Since not every state could confirm these criteria were currently valid for their list of certified peers, SSRS included screening questions at the beginning of the survey to confirm both eligibility requirements. SSRS programmed the survey instrument on its web platform. It was programmed in English and Spanish and optimized for administration via smartphone or other mobile handheld device. For this study, SSRS conducted cognitive pretest interviews with 5 certified peer recovery coaches from FORE's network. SSRS provided FORE with a memo including feedback on the email invitation, the survey questions, and the usability and clarity of the online survey instrument. In collaboration with the FORE team, we made some changes to the emails and survey instrument, and the IRB reviewed and approved all changes from the cognitive interview pretest. Data collection started in late October 2022, and the field closed in mid-January 2023. States varied in their method of contact. SSRS sent invitation emails and reminders to PRCs in Arkansas, Ohio, and Idaho. For the other 8 states, our collaborators for each state were responsible for sending out email invitations and reminders. To increase cooperation, a $25 virtual gift card was offered to all respondents upon completion of the survey. Now, as you can see on the slide, nearly 1,200 PRCs completed the survey across the 11 states, a total of 1,174 PRCs. Notably, the response rates in most states are relatively high, which is typically an indicator of high data quality and likely enhanced by the close partnerships with state certification boards, as anticipated in the survey design. The lowest response rates were in Ohio and Idaho, the 2 states where we use publicly available lists. Unlike the other states, the sample for New York was not a probability-based sample, since OASIS, our partner in New York, does not have access to a full coverage list of all certified peers in the state. Thus, we're unable to calculate a response rate for completed interviews in New York. Importantly, the findings and conclusions from the study reflect those who responded to the survey and should be used cautiously in any state or national level comparisons.
Robin, thank you so much. And again, both a detailed methodology report as well as the report on survey findings are available on our website. Next slide. So let's get to the findings and what we've learned. So firstly, to pick up on Robin's last point, we do want to frame the survey results with an understanding of who responded to the survey. And you see some of the demographics of respondents here. Most of the respondents were in the age group of 30 to 49, and a good share, about a third, were older than that, over the age of 50. 2/3 of our sample are identified as female, as well as 2/3 identifying as white race, with about 1 in 5 identifying as Black or African American. Nearly 70% of the sample reported a household income of under $50,000 a year. And note, we can go back a second, and most peers had come to the role fairly recently. In fact, fully 40% had become certified as a peer just in the last couple of years, and half the sample in the time period between 2016 and 2020. And the sample is pretty evenly divided between those who work full-time as well as those who work part-time. Next slide. So the first thing that really struck us in the data was that this is an incredibly highly motivated and mission-driven workforce. They want to do the work to use their experience to support others, but there are many concerns about the ability to stay in the field. We asked peers about what their main reason was for wanting to do the work of a PRC than to support people experiencing opioid use disorder. By far, personal experience and the desire to help others were the leading reasons that respondents gave. And to reinforce that, we also have had the opportunity recently to interview and talk with a couple of peer recovery coaches that are currently doing this work, one in Maine and one in New York. We asked our PRC in Caitlin in Maine about her process of becoming a PRC.
I like working with the folks in my community, the same community where I found recovery, and being able to support them and being the same person that my peer was for me. I'll never forget the night they cold called me. It was like 7:30. It was wintertime. It was cold. And I was like, wow, who is calling me at this late? And we got talking. And I wasn't really interested in what they had to say until they said, oh, well, I'm also in recovery. I have lived experience. I was like, oh, this might be a little bit different. That really is what helped build a connection. There's no way you can understand addiction unless you've been through addiction.
So while there's highly motivated, mission-driven population, we also asked about the likelihood of thinking they will stay in the field. And we found that about 15% of PRCs thought it was unlikely, somewhat or very unlikely, that they would still be a PRC in 2024. And that number grew to close to 25% when we asked out to 2027. Where just under half thought it was very likely that they would still be in this role. A good number of the peers in the survey started out as volunteers, and at some point went through their state certification process. So we asked why, and many of them did it because their job was requiring it of them, or so that they could advance and take on a different role in their organization. And we asked how easy or difficult the survey certification process was. And while the majority felt it was very or somewhat easy, we did see nearly a third of the respondents feel that they have some difficulties with that process, And often that was related to being able to find the time to do the practical training tied to the certification process, or identify classes to do the training, or having to travel a significant distance to get their training and their testing done. We did see that some state variation on this question, and you see here across the 9 states with a large enough sample to be able to do a comparative analysis. Quite a range of from 39% of those peers in Virginia feeling that they had that it was very or somewhat difficult, down to only 18% in Maine. We really got a sense from the survey of how varied the role of the PRC can be. PRCs report working in many different settings with people from many different backgrounds and engaging in a wide range of activities. And so it's no surprise that there's a challenge around in many places around defining what that job, what the role is, and what their job description is. We found that just under half of people felt that in their role was less than very well defined within their organization. And notably, we found that this is one of those points that is a differentiator. People who feel like their role is somewhat or very well defined were more likely to say they would still be in the role in 2024 compared with those who felt like their role wasn't well defined. And related to that, we see a real variation in terms of PRC respondents who say their coworkers understand their role as a PRC, with about 40%, 38% saying that they felt their coworkers understood their role very well, but a majority of our survey respondents feeling that it was only somewhat or not well at all in terms of how well their role is understood. We also see quite a variation with respect to the work settings in which PRCs are supporting their clients. In our survey response, a majority of our respondents say that are connected to a recovery community organization and do their work of supporting clients through an RCO. But we had 25% as well who are connected to programs in the criminal justice system through courts and correctional systems. And then much smaller percentages said their work setting is a more clinical setting, either a behavioral health setting such as a opioid treatment program or residential treatment, or a medical clinical setting such as an emergency department or a primary care provider's office. We also asked about how peers spend their time, and these next couple of slides just give you a sense. They're a little bit complex to get through quickly, but you get a sense here that very few peers spend 100% of their time on any one particular item. It's much more likely that the peers are providing many different forms of support and services for the people they are helping. And those include providing, we can go back one. Yeah, those include assisting with social needs such as housing, food, and employment, connecting people with legal services and assisting with legal issues. Next, helping to support recovery, stay on their medication or on their treatment plans, as well as providing specific counseling supports such as motivational interviewing. So given that wide variation, we were also interested in how well people felt prepared to take on their role as PRCs. We found that about just under half felt very well prepared, just over half somewhat or not at all prepared for their role. Again, this is a question that, this is a point that is a real differentiator. Those who feel that they were very prepared for their role and feel quite confident in their role were much more likely to say they would still be a peer and still in that role 5 years from now. Once peers were in their role, we also asked about what they found they needed additional training in or hoped to get additional training in. And the vast majority of peers identified areas where they would like to continue to receive training. This included how to work with specific populations, such as pregnant and parenting people or veterans, as well as a range of tasks related to their day-to-day jobs, how to be more effective in outreach, understanding harm reduction, using and helping their recoveries use technology, more work on cultural competence, as well as understanding medications for opioid use disorder and work training on ethics. The PRC respondents reported concerns with financial compensation and the stability or predictability of their financial situation, as well as varying levels of stress and burnout. Overall, 83% of the peers who responded to the survey said that they did receive some financial compensation for their work as a PRC. Again, we saw variation across the states with 95% of the peers who responded in New York, ranging down to 56% of those responding in Maine. And we asked about satisfaction with compensation. Just under 20% of those in the survey felt that they were very very satisfied with their compensation. So room for exploration across the majority of our respondents. But we also asked about their feeling the stability of their financial compensation. And we see collectively almost 7 in 10 were very or somewhat concerned that they would lose, that there would be a loss of funding to support the PRC position within the next 2 years. The survey asks about stress and burnout. 20% of our peers did not identify any symptoms of burnout or stress or significant stress. But across the 80% of the peer respondents, there was some range of some stress, but not feeling burnout, all the way to those who feel significant symptoms of burnout. We also asked whether this had worsened over the last 3 years compared to before the COVID-19 pandemic. And 40%, nearly 40%, 39% of our sample reported feeling more burned out than prior to COVID. And contributors to that stress and burnout are shown here. There's the emotional strain, the tough job of working with recoveries. Also not feeling well supported at work, working too many hours, and starting off with a caseload, which was really too hard to manage. So all components of thinking about how to better structure the job. Finally, in terms of how to strengthen the workforce and support workforce, we heard a few key factors around supervision, career advancement, and of course, better financial supports. Again, we're going to introduce one more peer to you, and this is Jason, who works in New York City.
The whole agency that I work at, we all are been incarcerated, former sex workers, former substance users. We call all of us a work in progress because doing this type of work, sometimes, yes, we fall down, but the way we pick ourselves up, we make sure we pick ourselves up as a team. The good thing about this agency that I'm at, that the work can sometimes be very difficult, especially when we deal with a bunch of cases. However, the director has stated that when we do need mental break, whether it's a week or whether we need to go away in a place just for our mental health, we are able to do that. Our job is always going to be safe. The first thing here is our mental health and ourselves being okay before we help others.
Thank you. So the other very striking finding to us is about the not only the importance and the type of supervision. 80%, over 80% of our PRC respondents felt it was very important or somewhat important to have a supervisor who had also been a PRC themselves. And they tied this experience with then having a supervisor who had a better understanding of the role, was better able to advocate for the PRCs within the organization, and better able to provide advice or guidance to individuals. And then finally, as we looked ahead and asked about career goals, many of the peer respondents identified a plan or hopes to continue their training and education, to continue to advance in the field. When we asked specifically about what would help keep them in the field, again, not surprisingly, 75% said a pay increase to better align their work and their financial compensation. But over 60% said having more room for advancement and career growth, and another 39% saying having the ability to further my education in the field while continuing to be a PRC. So a lot of opportunity to support people as they build their careers. Thanks. So just briefly, in terms of high-level conclusions, again, we really take away from this survey that this is a workforce population that's very mission-driven, but faces many challenges, partly because the work with people with opioid use disorder is still a relatively new and evolving field. We see that the tasks can be really varied, and the settings and the populations worked with also very varied. So while they feel passionate about this work, there are several challenges that we collectively can be working on with them. Compensation is certainly a significant issue, and employers, whether state publicly funded programs, Medicaid programs, or private funders, all need to be assessing what comprises an appropriate level of compensation. Thirdly, peers need recognition from coworkers and emotional support, as we just heard so beautifully phrased by Jason here in New York. And then finally, PRCs want opportunities to learn and build their career. And employers and others can really look at ensuring that certification and training opportunities continue for PRCs as they're in the role, as well as helping to support opportunities for them to continue to progress and take on potentially other roles within the behavioral health field. I want to thank our project advisory group members, which included Adrienne Brown, who's on our board of directors for the foundation, Dean, who you'll hear from shortly, Julia Felton, Karen Fortuna, and Jessica Magison, all on faculty studying and developing training programs, as well as Courtney Lavelle, who's now at the National Council for Mental Wellbeing and a member of the FORE National Advisory Group. Also, again, want to thank the team at SSRS, Robin Rappaport, Rob Manley, Elizabeth Supak, and Hope Wilson, as well as all of our state partners who we really could not have done this work without. Thank you. And now I am very pleased to welcome and turn the podium over to Paolo Del Vecchio, who directs the Office of Recovery at SAMHSA. Paolo, thank you.
Great, thank you, Karen. And let me say thank you to FORE and Karen, you and your whole team for this groundbreaking survey. You know, over the last 2 decades, we really have seen an explosion in terms of the growth of the peer workforce across the nation. And what your survey does is really does shed some needed light on these efforts even further. The last March 2022, President Biden announced in his Unity Agenda the importance of the peer workforce and noted the need for national model standards for peer certification. this was really the first time ever that the peer workforce has reached the level of the highest part of our nation, and the president himself acknowledging the value of peers working with peers. I was really struck with a number of your findings here, and I'll reflect on each of them. What really excites me is the alignment that these findings have with our just released national model standards for peer support certification. And I'll put in the chat here the link to that particular release last Tuesday that President Biden called for in his remarks as part of the Unity Agenda. So first on the issue of equity, and your findings here that only 1 in 5 peer recovery coaches identify as being Black, 1 in 10 identifying as being Hispanic. And what this really speaks to is the need for equity, the need for us to do a much better job across the nation in terms of recruitment and retention of peer workers from diverse communities. We know certainly in public behavioral health that the numbers certainly are much higher than what we're seeing in terms of the peer workforce. And what our goal really should be is for the peer workforce to be very similar to those that they're serving across the country. So the need for equity, the need for us to do a better job of diversity, equity, inclusion, accessibility is clear, and your findings certainly point to that. Second is regarding the whole finding that people are mission driven. And we do know that people in recovery, this is work that comes from the heart. This is about giving back to our communities and giving back to those so, people can, as was reflected in those great videos, that sometimes you can only connect with a person who's been there themselves. And that's what the peer workforce brings to us. It brings that sense of connectivity. It gives us a sense of a role model that you don't necessarily get in traditional treatment programs. And, it's the passion that we bring to the work as peers, as people in recovery that clearly is reflected here also in these findings. Of course, it's concerning that, we're seeing the numbers of people who may be considering leaving, but, I'll also reflect that these numbers are in fact lower than general employee populations across the country. So when you look at the general workforce, then the percentage of people who think that they're going to be leaving in 2 years is about double of what we're seeing in this particular finding. So again, to me, what that says is about the mission driven, how people truly are committed to this work, not only for the short term, but for the long term as well. That doesn't mean that, we don't need to look at ways of supporting people so that they stay for the long term. But I think it is important to recognize that people are dedicated and committed to the work. When we also look at, this issue about ease of certifications and the findings there of the great diversity and how states currently certify people. And that's one of the main reasons that our national model peer standards were developed, because there is a patchwork across the country. It's apples and oranges in terms of the requirements, and the need for having a more uniform approach to certification across the country will help improve quality among all, and will also help set the stage for reciprocity and the need to cross state lines, as many of us do, in order to carry out peer workforce efforts. When we talk about the issue about defined responsibilities, and that is something, again, that we hear from peer workforce all the time, that as peers are brought into jobs, that their roles aren't clearly defined, particularly the need to help educate others within an organization about the value add that peers bring to the team. And this is a really critical point, that we don't want to create a necessarily unhelpful behavioral healthcare system simply with peers inserted in the care delivery. And what peers bring is something unique and value added to the care delivery system. And it's important for us to acknowledge that. It's important for us to celebrate that as well, and to train the fellow team members about the roles, responsibilities, and values that peers do bring. Your findings also talk about, the varied ways that people practice individualized care and practicing many pathways to recovery. And this really heartens me because this talks about the essence of peer support and that people are being authentic in terms of how they're carrying out this work. Areas of training, and here again, as we developed our model standards, we heard this from throughout as well, the need for comprehensive training, but also ease of training in order to get people work in that training that helps people do their jobs better. In the area about looking at compensation here, this was also an interesting finding. Again, when you compare the data to the general workforce, we know, of course, peers need to be paid a living wage. Too often we're not. And there are interesting reasons for that. One can conjecture certainly is the, what we've called stigma in the past, the prejudice and discrimination. If we are not valued by society, our work is not necessarily as valued, perhaps we won't get compensated, accordingly. And the need for states, the need for organizations really to look at a living wage and opportunities for advancement is critical. That being said, when we look at this data about the number of people who indicate that they're satisfied with their pay scales, again, in comparison to general workforce, it's actually lower in terms of people being more satisfied than the general population. Again, that doesn't mean that we need to have people paid a living wage. This issue of burnout, this is another area where, in fact, when we compare peer workforce with other healthcare workers, right now, particularly in the wake of the COVID pandemic, healthcare workers were reporting 50% burnout rates, 1 in 2. And yet, this data shows lower rates of burnout. And for the peer workforce, again, to me, this is something about the resiliency and strength of peers working in these systems. It is hard work. It is very tough work to go and working back within these care delivery systems, but people are truly resilient and we need to recognize that. In the area of supervision, this is another area in the national peer standards that we touched on. And our recommendation here was, in fact, to have supervisors who've been peer specialists, recovery coaches themselves. So very much in alignment with what these survey findings are saying, that in order to truly appreciate and recognize the value, you need to have somebody who's supervisors, somebody who's been trained as a peer workforce employee as well is really important in creating that welcoming environment that people will feel appreciated and respected. So we looked into the issue about career advancement, and I'm just about done with my comments here. And this is another area that we hear frequently. And again, this applies to the workforce as a whole as well. We all want job advancement. We all want a pay increase. And so particularly for peer workforce, the need to develop career ladders. So, as we look at developing peer workforce within organizations, the need to look at how can people advance over time to become supervisors, in fact, to be able to work in particular settings so that they can grow as individuals, they can grow to help improve organizations, ultimately to help improve the lives of people that they're working with. As I end, I just want to reflect really quickly on, again, thanking FORE for this outstanding work. Of course, we always talk about when we do research, the need for more research. And here that's clearly the case. The data that we have on the peer workforce is still in its infancy. We need to know things like, for instance, how many peer workers actually are working across the country. We have estimates anywhere from 25 to 30,000 at this point, but we need annual estimates to really know. And we need to know things, for instance, are there particular areas geographically where there are a paucity of peer workers so that we can look to increase in those areas, perhaps in rural areas or urban areas or other parts of the nation. So having that kind of data, I think in the future would be really critical. I also think this issue about, we talked about, finding here about specialized populations. And the need for us again to look at data, how many peers in fact are working with justice involved populations? How many peers are working with youth and with families? This is the kind of data as we look to grow the peer workforce, I think will be crucial over time. And let me end again my remarks where I started, and that's on the diversity and equity issue. And again, we can do better. We can do better from a recovery community perspective. We can do better as policymakers, as states, in terms of really moving forward and advancing equity, not only across behavioral healthcare, but within the peer workforce as well. So thank you again and thank you for the opportunity here to reflect on this just outstanding work.
Paula, thank you very much. Back up here. Thank you. And I am going to turn it right over to Dwayne Dean, who is at University of Maryland, and again was on our project advisory committee for this project.
Thank you, Karen. And thank you, Paolo. You touched on a lot of good points. And after you guys just spoke, I don't know if I have much to say. You touched on just right where we're at with just the advancement of the peer workforce. Paolo talked a little bit about just the clarity around the role. What we've been noticing is that there's a need for education around role clarity. With peers rapidly increasing in organizations across the nation, what we're finding is that the organizations that are receiving them, the providers, the programs that are receiving the peers are working with, we're understanding that the organizations themselves have lack of understanding around the role, which doesn't allow for the peers to preserve the role, and we lose our effectiveness if we're not operating within our role and within our responsibilities. A lot of times when a peer enters into the workplace, sometimes they're pretty much asked to do some of the things that other clinicians that has been there already are doing. One of the examples that I use is that we're not the same as counselors. We fit intricately into the puzzle of recovery-oriented systems of care. We fit really good into that piece, but we're two different animals. It's like a baby rat and a mouse are two different animals. They look the same, they may do some of the same things, but peers have their own specific role. And if we can maintain role clarity, we can maintain our effectiveness. The effects of the peer role on personal recovery is evidence-based. It's been proven that it's very effective with the relatability, the role model, the mentoring, different roles that peer recovery coaches operate in. In a minute, I'll talk about some of the tools that is evidence-based that we've been using to help further the effectiveness of the peer role. And one other thing that I'll touch a little bit on is just creating networks. It's not, as Paolo just mentioned, it's not uniform across the country when it comes to certification. Some has to do with just different states' autonomy when it comes to Medicaid reimbursement and just the peer certification in general. Next slide. So one of the evidence-based trainings or evidence-based interventions that I've been actually honored to be a part of is called behavioral activation. We've been using it for about 5 years now. It's initially was very effective in treating depression, but we found it super effective with treating substance use disorder when it comes to adherence and retention. And I'll explain some of the components in a second when it comes to behavior activation. But first, just to give you an example or just to explain a little bit of what behavior activation is, it's simply a intervention originally developed, like I said, for depression, but we have adapted it for substance use disorder. BA aims to break the cycle between negative thoughts, behaviors, and feelings through scheduling positively reinforcing activities into one's schedule. It's generally straightforward and brief. It has been found to be feasibly delivered by peers and leading to positive patient outcomes. We've been able to deliver this structured intervention in the preservation of the peer role, so allowing the peer to still operate in its most effective way. Just to explain a little bit about BA, or as we call it, behavior activation. Behavior activation, just the core components of BA is psychoeducation on the cycle of substance use. And we're talking about negative feelings that leads to urges, and those urges that leads to negative behavior, which just creates that negative cycle of substance use. We get the peers to actually identify where it is in that cycle they can break that cycle. And of course, it's in between the urges and behavior. And we do that with substance-free rewarding activities. We then get the peer to actually identify how to break that cycle and enter into a more positive cycle of behavior. Once educating them on that, we introduce them to monitoring their behavior, because we just feel like you can't fix what you don't face. So we get them to take a look at some of the things that they're already doing in their lives. We help them to define what values are in different areas of their lives, such as relationships, maybe in hobbies, maybe in spirituality, but most of all in their recovery. We then we take that information, or when armed with that information, we help them to schedule activities that are rewarding, that's substance-free and rewarding. And rewarding can be productive or enjoyable activities. We introduce them to the SMART tools, SMART goals, so that they're making goals that are specific, measurable, attainable, relevant, and time-based. We also introduce them to social supportive contracts, because one of the things we realize that the people that does offer support to us offer the support the best way they know how, but sometimes it's not the best way that we need help that's conducive to our recovery goals. So the importance of peer-led training, when we're talking about training peers across the nation, some of the things that we've been finding is that some of the subjects that we are teaching, some of the domains, we find the need today for more trauma-informed training, for peers to learn a little bit more about adverse childhood events, stigma, implicit biases, unconscious awareness. So we've been looking at the curricula and trying to implement more curricula that is more suitable for the population. As Paolo also mentioned, when it comes to diversity and inclusion, we're finding peers in so many different environments and dealing with so many different populations. And those populations can be, they can be split up in different gender. It can have something to do with gender, class, race, socioeconomic class, urban, rural areas. So just trying to make sure that the peers are more equipped or better equipped for the population that they're serving. When training, we use different learning styles. We try to make sure that it's just not teaching the science and the theory of fundamental peer skills, but also making it more practical using scenarios and role play and maybe the whiteboard or polls. So we're definitely trying to make sure that we're capturing different learning styles. The importance, I want to talk a little bit about the supervision, because again, Paolo, and I keep coming back to you because you raised so many good points. We're looking for supervisors that have lived experience. You know, they can best help in the workforce with peers, with advocating for them, and helping them with other things that become a little bit more personal, like self-care and just direction, role model, and mentoring. So it's super important that peers are supervised by other people with lived experience whenever possible. So when we're talking about best practice and future directions, we're looking to hopefully, with some of the data that's been collected, although states have their own autonomy, just looking for more uniform practices when it comes to certification. I, for example, have experience in this area where I'm about to move from one state to another. And with all the experience, with all the credentials that I have, none of them are reciprocated, or none of them are has any reciprocity in the state that I'm moving to. So I'll be looking to pretty much almost start over if I'm going to do work with the population in that state. So that becomes a problem for peers that want to cross state lines, that want to work in different areas and different environments. The reciprocity, you know, it's patchy. It's really patchy. There's no one uniform approach when it comes to peer certification or reciprocity. Clarifying the peer roles and responsibilities for agencies and employers, I believe, is one of my top priorities, and just a pet peeve of mine that I do a lot of work in that area, just educating and teaching providers and organizations with how to use this effective tool, how to use the effective tool when I'm speaking of the peer workforce. We're very effective, but it's just like if you keep turning a Phillips screw with a flathead screwdriver, eventually you're going to strip the screw. So where the tool is very effective, but are we using it effectively? I would like to also see, and just in closing, just to see peers, Paulo talked a little bit about just enlarging the coast or raising a ceiling. You know, we have peers in community organizations, criminal justice settings, hospitals, residential programs. Other than peer supervision, the ceiling is really low. I would like to see more peers at SAMHSA, at the DEA, at the Food and Drug Administration, you know, sitting and having these conversations when they're allocating money to different recovery resources or different recovery initiatives. You know, we want to kind of work towards raising the ceiling for peer recovery coaching. I believe, in closing, that we have evidence-based interventions. We have evidence-based information when it comes to peer recovery coaches. So it's not a mystery of the effectiveness of peer recovery coaching, but as a whole, just to take a look at what we're doing, because we've come a long way, but I still, in my opinion, believe we have a little more ways to go in just making this tool beneficial for the whole. Thank you.
Wayne, thank you so much, and certainly great contributions to the discussion. And now I'm pleased to introduce Justin Reed of the Portland Recovery Community Center. Justin. I think you have to unmute yourself. Yeah.
That would help. Thank you. Good afternoon, everyone. My name is Justin Reed. I identify as a person in recovery. For me, that means I have not used drugs and alcohol since December of 2014, and have made beautiful connections with people in the recovery community, my overall community, and have the opportunity to participate in things like this. And ultimately support peer recovery coaches and those in recovery. So first and foremost, thank you to FORE and SSRS for compiling, collecting, presenting all this data. To be fully honest, there's so much data here. I just keep going through it and highlighting more and more and figuring out all the ways that it can be used within our state to help support the folks in and seeking recovery. So this information that I'm going to mention is not necessarily in order of importance, but just some of the pieces that I found going over the data. And just to give an overall snapshot, I would imagine that Maine is more in the infancy stages in regard to peer recovery coach credentials. In 2016, when I first participated in the Recovery Coach Academy, there were a few trainings for peers being offered, but really no follow-up. Fast forward a few years with the help of the current administration, folks like Gordon that you're about to hear from in a few minutes, we've been able to really build up the amount of RCOs within Maine. And then also in 2021 was when the Recovery Coach Certification Board in Maine was incorporated. So it hasn't been that long, but in a short amount of time, we've really seen a lot of progress within the peer world and the organizations employing peers. So this information and data is really helpful in helping determine how we may best support the peers and organizations that are employing them. So also, side note, really awesome to see the video of Caitlin a bit earlier, because I remember, I think at the beginning of 2021 when she participated in a peer training, and then just to watch the development and see her practicing professionally in a professional capacity as a peer is what it's all about, and aligns with, you know, the journey of recovery itself, just seeing somebody come through the door and then continue to evolve and find that purpose and really just, you know, help others in the community. So thank you, Caitlin, for continuing the journey. All right, so as part of my role as a statewide recovery coach coordinator, I help to deliver the trainings around the state for the Recovery Coach Academy ethics and the wraparound trainings that help to support coaches and their foundational knowledge. I also help to support the recovery coach coordinators at the individual recovery centers, and most importantly, the recoveries that are being served by those individuals and places. And I just say that because I think this data, you know, branches out and covers all those areas and how it may be shared and help support the folks doing the work in the field and supporting coaches. So pieces like the ease of the certification process are very helpful in being able to relay that to the certification board. And also we've had a bit of collaboration with some of the participants of this survey, talking about how can we have some work groups and collaborate among states that participated to, you know, get helpful pieces of information on how we can improve in some of the areas that we're lacking, and then hopefully return the favor in other departments. But it was really great to see that coaches are, I would say, overall feeling valued as skilled professionals, and in regard to the stigma components as well, how much they're feeling stigmatized. You know, not at ideal levels, but I would say if we went back a few years, I feel like these numbers would not look so good. And I think that really is about creating cultures and communities that are embracing and supporting recovery. And that's taken a lot of work, and we're still, you know, there's still a lot of work to be done. But it is very nice to see. And, you know, peer coaches are professionals, so I really hope they are being treated that way. And then Paulo touched on it, and I believe Dwayne did as well, but talking about the role clarity and the supervision of peer coaches in our state. I believe there was about a 50-50 mix of coaches that were being supervised by a peer recovery coach themselves. 36% said they didn't know if their supervisor was or was not, but I feel like if your supervisor is, they really will be demonstrating competency and understanding what the role is. And as was mentioned, the role clarity within organizations is important, and it is hard to really define a role for a peer if we don't know what that entails, what the model entails. So it does also validate some of the work we're currently doing in regard to a campaign to help employers understand and get the training around what is the role of a recovery coach. How can I become a coach advisor or supervisor of recovery coaches that would meet the standards of the state certification board, and really, help to sell the idea. And it's not really selling, but just proving to employers the importance of having folks that understand the peer model, because as reflected in the data, the coaches in these organizations will then feel more valued, have that role clarity, and be able to go do their work instead of being pulled into areas that really should probably not even be in the peer realm, whether that's clinically speaking or otherwise. So it was, also nice to see that supervisors or coach advisors are supporting coaches and allowing time for self-care. And again, I think this goes back to, are we creating cultures that are not only allowing time for that self-care, but how do we take that a step further and say, where coaches are being asked to serve, are we creating a culture that is encouraging and promoting the self-care, not just saying I'll give you time off when you request it because you're really struggling? How do we prevent getting to that point? Seeing that 26%, so a quarter of coaches are feeling often under stress and burnout. I believe we then can take pieces of data from other questions and say, how can we really encourage those folks and be supporting those folks using some of the methods that other coaches have shared are working for them, such as listening to music or meditation, attending support groups, all those things, and just really reducing those numbers that are going to take that burnout down. Because it was also great to see, because of that drive that peers have, and I believe the value they're seeing in the work they're doing, that they want to be in these positions, these peer roles 2 years from now, 4 years from now, whatever the case may be. It's it's within their heart, so they're going to continue to do it. But then also pieces of the data about the compensation and how we can bring that more into the equation. And again, being newer in the recovery coaching world in Maine, there are a lot of newer organizations, not newer organizations themselves, but organizations that are incorporating peers within their organizations. So how do we support them, and how do we support the peers within them to be the most successful possible and be able to continue that work for the long run? So let's see. The last piece, it aligns with that 90% of our paid peer recovery coaches are concerned about budget cuts. So how can we, or the folks employing recovery coaches in our state, or state government, etc., really help to alleviate the fear of the budget cuts and create a system that is sustainable, and look for funding options, such as, for example, currently on the table is in Maine is a proposed 12% of the cannabis tax being utilized and designated for recovery community centers, things of that nature that appear to be sustainable and are going to be directly going into the work being done by peers, is something that would be great to see. So we don't have to have peers being fearful that they may not have a job in 6 months or 12 months or when an administration changes, but they can just focus on the work in front of them. And that is all I have. But again, just very grateful for this information. I'm sure there's a lot more pieces that will come about as I continue to review it. So thank you.
Well, Justin, we're very appreciative of having you with us this afternoon, and thank you for sharing um, your expertise as well. And we're gonna stay in Maine and turn it to your colleague, Gordon Smith, who's director of the opioid response for the governor's office. Gordon.
Oh, good afternoon, and thank you to FORE and SSRS for the survey and the opportunity to comment on it. It's a real privilege to follow Justin, who's done a great job in leading our hub in Portland in terms of recovery coaching. Recovery coaching in Maine has, in the past 4.5 years, been a very important part of our opioid response. And we think now that there's probably 1,500 coaches that have been through the academy curriculum, and now we have additional curriculums for, as you know, for ethics and work in the emergency department, more specialized curriculum, and we keep developing those, and I'll talk about a couple examples. So when Governor Mills was first elected in January and took office in January 2019, in Executive Order 2, there were 4 items that were specified that we wanted to do immediately. And one was to train and recruit and train an additional 250 recovery coaches. And by this time, we have probably trained 700 or 800 in additional to the ones that we have, to the point where, as I say, I think we probably have 1,500. They do operate in a variety of settings. Most of them are not full-time paid employees of anyone, although that is becoming more common. So in terms of my reaction to the survey, which I found very interesting, there was nothing that jumped out at me that was a shock. It did confirm a lot of our thinking in terms of what we've seen in Maine. And actually I was pleased to see actually how well recovery coaches were doing in these other 10 states, frankly. That I come out of a healthcare background, a lawyer for healthcare, doctors and stuff, organized medicine, if you will, until I began this work 4.5 years ago. And so if you really look at the issue of burnout, stress, job satisfaction, advancing in your career, do you expect to be doing this work in 2 years? Actually, the numbers in this survey are quite positive compared to, particularly compared to other healthcare professions. So I think for such a new field, that I was pleasantly surprised at how low the levels of dissatisfaction were, so to speak. It's difficult work. We found that with our behavioral health liaisons that we have. And so I'd almost expect the burnout and stress factor to be higher. The 2 of the new areas I wanted to mention that we'll be looking at, that the governor announced in December and January, was we're going to train some youth, some adolescents in recovery coaching to be recovery coaches to be peer support for other adolescents. Most of the youth groups that we have started, the youth caucuses, are not, frankly, youth who are using or in active recovery. They're adolescents who have experienced this in their families. Maybe they've lost a sibling, maybe they've lost a parent, perhaps the parent is in prison. And so we know that we've had enough experience with them now to know how much support, how much it means to have a 16-year-old share with another 16-year-old. It's way different than myself and a large group of other people my age with my experience talking to adolescents who are the age of my grandchildren about. So I think that I'm very excited about that initiative. And then even more so, we're training people who have been through the Office of Child and Family Services experience. People have had experience in the child protective system, but have emerged from that system, regained custody of their children, who are now in long sustained or sustained recovery and are doing well. And we want to train them to go and help the people that are in the system now, which are hundreds of people, of course. And no matter how benign we try to make it, the arrival of a child protective worker in your home, in that home, is going to be viewed negatively, to say the least. And to be able to connect that family, a mom, a dad, with people who have been there and can say, Marianne, I was right where you were 8 years ago. And now my children are with me. We're doing well. It's the peer-to-peer. The thing that I've learned most, and I was certainly no expert in addiction when I started, and I'm certainly no expert in addiction now, but I have seen the value of the peer-to-peer connection. Another place where we see it, frankly, is in that emergency department. There's been so much stigma, in healthcare. Again, plenty to go around. I don't mean to pick on healthcare because it's there in corrections, it's there in the public, it's there in public safety. But when it comes from the profession, the caring profession, it's even more offensive and striking, I think, to the individual who is struggling with a substance use disorder. So we have attached recovery coaches to 8 of our 33 emergency departments. We're about to go to 10 because we see the benefit of being able to, if that individual, after they've experienced perhaps an overdose, or perhaps they are in the hospital for a medical condition, when we're able to say, gee, we'd like to connect you with John. John was here a year ago where you are. This is what he's doing now. He's mentoring, he's coaching. I just really believe, I think the whole administration, the people I work with every day, really believe in the power of this peer work. We've seen it in the mental health field, and now we're seeing it in the substance use disorder field. And so I think that the survey helps to confirm the strength of the movement. It helps to confirm that many, many people who become recovery coaches and have active positions in recovery coaching, feel that it's such a strong part of their recovery to give back to others who are struggling. It's a beautiful thing. And I'll close because we want some time to answer your questions by just saying that we really in Maine have a very robust recovery community. And so I get asked a lot, gee, with so much focus on our increases in mortality and overdoses and the shortage of treatment at times, your job must be very difficult, must be very sad. And every Monday I'm given the total of how many people died the previous week of an overdose and how many people were saved. And it is painful. It is sad at times, but we get our energy from the across this country, the tens of millions of people who we know with many of forms of the treatment that are available now are doing, the chances of them getting into long sustained recovery are 3 out of 4. And those are way better odds than before we had some of this treatment available. So we're robust optimists up here, and I just appreciate being able to share a few minutes with you. I really, again, appreciate the privilege of being on this Zoom this afternoon. I've just recently had an opportunity to meet Paolo, and I think the fact that there's a Office of Recovery now within SAMHSA is just such a fantastic thing. So thank you.
Gordon, thank you for being with us. And I'm going to turn over to my program director, Dr. Ken Shatskis, who's going to moderate the questions.
Yes, let's bring all of our panelists back on camera so that we can have a quick discussion. I know we only have about 12 minutes or so, and there was a lot that we covered very quickly. And you can take off the what's it called, the session, and let's just grab everyone else back on if we can get Dwayne back on.
It won't let me.
Oh
Okay.
no, I got, maybe I have to.
There we go. There we go.
You have to do
Good.
it again.
And Justin, all right, we have everybody, excellent. So again, thank you everyone. That was just like, it was a wealth of information, and I feel like I can ask a ton of different questions. But I'm going to start quickly, first with Paolo, and you spoke to expand a little bit on the idea of a career ladder, for peer recovery coaches. We know that there's, quite a behavioral health workforce shortage right now in the country. And this is a workforce that we see is mission driven, that wants to do this work. So as we think about a career ladder and filling potentially those gaps in areas where peers may be, and we may not have other behavioral health workforce professionals there, how is SAMHSA thinking about that, and how we develop this workforce into a sustainable group that can help?
Yeah, great question, Ken, thank you. Some states have actually developed job classifications to enable people to move up in their careers in the peer workforce. And, one of the things that we do have, and I'll put this resource in the chat as well, is the Peer Recovery Center of Excellence. And that's a National Technical Assistance Center that's focused on advancing the peer workforce across the country. So identifying these models of how states have begun to address career advancement, I think, is one strategy.
Thank you. I just see in the comment there, in the comments, recovered people help recover people, and I love that. I love that sentiment, and I want to go now to both Justin and Dwayne. We could go one after another, but we had a great question in here and relating to supervision. And particularly someone wanted to know, for those that are supervisors of peers, that aren't peers themselves, do you have any tips? Do you have any lessons learned that could help those individuals? Because we do know that many peers right now are under the supervision of potentially a medical physician or another different profession. So Dwayne, why don't you start off first?
Absolutely. One of the things that I've been doing is doing some consulting with organizations with this exact question, like, what do we do with our peers? And one of the things that I enforce is education. Learn the foundational peer skills, learn the roles and responsibilities of a peer. I actually taught an amended training to providers of organizations, teaching them the same skills that we teach peers, so they understand how we do what we do when we do what we do. And I think that's just firsthand knowledge, so they get to see it in action. They get to understand. It's one thing to see the work that peers are doing, but when you sit in a class and it's a practical, very interactive training, and you get to understand, okay, now I see why they do what they do and how they do what they do. So I just think that it's very important that, and we have a foundational training that I don't own the curriculum. CCAR owns the curriculum. It's Recovery Coach Academy. It's a 30-hour intense training of practical training of just foundational peer skills. So that way the provider understands how the peers do the work, what the peers are seeing. They get to see it from outside of the fence, instead of, because a lot of times what we find is it's just a matter of perception. I may see a 6, but from your side of the fence, you see a 9. And because of that, we assume, we believe we have a general understanding, and sometimes that's just not enough. You need to have a really specific understanding of the roles, responsibilities, and the core values of peer recovery coaching.
Sounds like taking the time to learn about that role for the peer. Exactly.
Absolutely.
And Justin, how about you?
I would say that that component is spot on as far as if we're including certain requirements in our peer responsibilities or, you know, foundational knowledge through training. It only seems sensible to have the folks supervising those peers also have that same knowledge. And I think along with, it's not just training and information, but within those trainings of peers, you're hearing stories. And if supervisors are willing to hear those stories, you know, especially if they're not identifying as a peer themselves, which is going to happen sometimes, I believe, then they'll have an experience and start to shift those perceptions, potentially stigmatizing perceptions. And also I would say that supervisors, if they're willing, hop over to a recovery community organization if that's available and see what these concepts of multiple pathways of recovery are all about, meeting people where they are, what that's all about, because I think a lot of people just have you know, perceptions that recovery is clinical or recovery is 12 steps and don't have the holistic picture here of all the different opportunities that folks in recovery have and can utilize.
Right, and I'm gonna follow up really quick because I want to keep talking to the peers here. That you know, I do this work day to day, and you know, we have another question here about, you know, if anyone's looking at, you know, peers and experiencing relapse or experiencing relapse, you know, and generally, you know, we know that this is a population that does need to be supported themselves. So as supervisors yourself, I'm just curious, you know, how do you, you know, work with peers that may be dealing with relapse or dealing with, you know, any sort of mental health crises that they may be having in their role? So we can start with Dwayne again.
I would have to say with this is my last mistake has always been my best teacher. I had a peer that I was supervising and that worked on a team with me in the emergency department that experienced a reoccurrence. And because of that, I started implementing with my peer supervision, just wellness recovery action plan, just a wellness recovery plan where when I hire a peer, that I get them to tell me, how are you when you're well? What are some of the things you do when you're well? That way I'm also can help and look and monitor and see, hey, if this person says they are on time when they're well, they dress a certain way, they get their nails done. I don't know, whatever they say they do when they're well, when I don't see that, I can ask them. And this is going to be information that in my opinion, it's probably not going to be shared with a person that doesn't have lived experience. If my supervisor doesn't have lived experience, I'm not going to feel comfortable telling them that I feel like my self-care is not being maintained, or that I feel like I feel on the verge of reoccurrence or things of that nature. But I will feel way more comfortable telling that to my supervisor that has lived experience. So just implementing that helped me to just be more vigilant when it comes to burnout and self-care, and just supporting the peers that worked along with me in that manner.
Great. And Justin, any tips on that?
I believe that's a piece I failed to mention that I had jotted down, was just identifying that peers are people in recovery too. And I don't believe that myself or any other coach advisor or peer doing this work should be put up on a pedestal, because we're not. We're just humans in recovery, just like the people we're supporting, and may have some more pieces of information and develop routines that work for us. But recently had somebody ask us from a different outside organization, what does your employee assistance program look like, or something of that nature? And I said, to be honest, I really hope our staff members are facilitating or embracing a culture where people are just feeling open to come to us when they're struggling before that happens. Or if a recurrence does happen, I believe it's always been the case that our peers have come and just been open about that situation, because I believe they know if they do that, or feel that if they do that, that they'll be supported the same way that we're supporting the recoveries we're working with. It's no different. Like, what can we do to help you today? What do you need that's best for your recovery? And then decisions can be made later on down the line in regard to Somebody might need to take a 6-month, pause from delivering coaching service. Somebody else might be a year, but that's really all dependent on how they're feeling and what they're doing for themselves in their recovery.
Treating everyone as an individual. Exactly. And Gordon, we have a question in the chat, and I am asking you this because we were on a webinar on opioid settlement dollars a little while ago together. So just curious, someone's curious about how can opioid settlement dollars be potentially used to improve or shore up the peer recovery workforce, and how is Maine thinking about that?
Well, we are thinking about that, and I think everybody can think about that. Every state, the way the dollars are divided up, who's in charge of them, it's all a little different. And so we do in New England particularly share a lot of ideas. There is the mitigation document as part of the national settlement that says how the dollars can be spent, whether they're in a municipal subdivision, a county, a state. So, and clearly all recovery services would be in the A or B category of permissible uses of settlement dollars. So I think we're all excited to have this new source of funding. It's not the kind of money we saw in the tobacco settlements for those of us who have been at this a long time. But the good news is that we didn't do a good job of protecting the tobacco settlements for tobacco prevention. We have protected all this money. It's not as much money, but it's much better protected. And I know in Maine, I mean, we don't think that any one of our pillars of prevention, treatment, harm reduction, and recovery support should receive, an oversized share. Prevention, it's not exciting, it's not sexy, it's just the most important thing is to have fewer people start down that road and deal with everything from trauma to adverse childhood events. So I absolutely believe in Maine that all of our recovery activities, recovery centers, recovery friendly workplaces, recovery coaches, recovery residences, all will be better compensated. There'll be more of them because of those settlement dollars. So thanks for asking that question, Ken.
Thank you. Thank you. Sounds like a very holistic approach there. And I'm going to squeeze in one more for Robin on the methodology aspect. We do have one question that is actually, discussing about the differences in the survey responses and the sampling, particularly around the 2 states that had public lists. So I don't know if you saw the question and you want to think about it. Yeah.
Yeah, I did see the question. I think it's a little complicated, but the one thing I wanted to point out is that for 8 of the 11 states, the outreach efforts were directly by the organizations and the boards that are connected with the peers. And those were associated with the highest response rates overall. And I think that kind of close collaboration, which allowed for the outreach to be with the certification boards that were familiar to the peers, I think was what helped drive some of those response rates to be the highest. I think some of this question around kind of the quality of the lists, we don't have enough information really that tells us that they, how great or bad they were, except, what we have in terms of sort of the bad emails. And that suggests to us that overall they were, in decent shape. But that some of the publicly available lists seem to have higher rates of emails that were not valid. So that is some information suggesting some of it's not updated as often.
Great, thank you. And with that, I'll turn it back over to Karen, I guess, to end us off here.
Thank you, Ken. Thank you for moderating, and I just want to thank this terrific panel, Paulo, Gordon, Justin, Dwayne, Robin. It was a real pleasure working with you on this, and we hope that it's just a contribution to continuing the discussion and continuing to strengthen this workforce. I will just flag, there was a question about making the questionnaire available. Robin and I communicated on the side, and we will update the methodology report with a link to that questionnaire, so that will be available in the coming days. We should get that done. All right, thank you all again. Have a good afternoon.
Take care.
Thank you, everyone.